Good evening, and thank you very much for joining us this evening on your weekly segment of Health Digest, where we discuss issues that affect your health. And today we are discussing diabetes and living with diabetes. On the 14th day of November this year is World Diabetes Day, and the theme this year is on diabetes on women and children. Now, about 5 to 10% of Kenyans are said to be living with diabetes, and out of this, 60% do not know that they are diabetic. And with me to discuss these issues around diabetes, how it affects your health, how to find out whether you're at risk of diabetes, if you're suffering from diabetes, and how to manage diabetes, are two doctors, a doctor and a pharmacist. We have Dr. Kibasho Mwangi. Dr. Kibasho Mwangi is the head of non-communicable disease at the Ministry of Health here in Kenya. He is the co-chair of the Kenyan Lancet Non-Communicable Disease and Injuries Commission, which is part of the Global Lancet Commission on reframing the non-communicable disease and injuries. He's also a public health graduate from the London School of Hygiene and Tropical Medicine. He is a fellow of the Royal College of Public Health. Also with me is Dr. Robert Kimbui. Dr. Kimbui is the chief pharmacist of Good Life Pharmacy Limited. He has 12 years of experience spanning health system strengthening, supply chain management, regulatory affairs, public and private partnerships, and pharmaceutical distributions. He has worked in various sectors, including the Ministry of Health, Laborex, Médecins Sans Frontières, amongst others. And we'll start by just sensitizing you. As you can see, I have a lapel pin, which will mark this year's theme on women and diabetes. And Dr. Kibasho will just explain to us what this lapel pin for this year's theme on diabetes.
All right. Thank you, Dr. Aria. This is actually a running campaign that has been there for quite some years. It's a campaign that was fronted by the IDF, the International Diabetes Federation, and together with the Ministry of Health, it's Unite for Diabetes. As you can see, it's blue. Blue is the color of diabetes, and it's a circle that calls on governments, on individuals, on the private sector to unite around this month of November to call for access to diabetes care, to call for screening, to call for care about the diabetes patients. So it's a clarion call for everybody to rally in support of the people who are having diabetes, those who don't know about diabetes, and especially the campaign heightens around the 14th of November. So we usually pin personalities so you can feel proud that you're one of those that we have just pinned. And we hope that whenever they have those platforms like you do to highlight issues of diabetes and non-communicable diseases, that it's a challenge, and governments and private sector need to take it more seriously.
Okay. Now, amongst these statistics, as I had done in the introduction, is that 60% of Kenyans do not know that they are diabetic. And earlier on, we had run the story of Catherine Dwiga, who was diagnosed with diabetes from the age of 5. Now she's 35 years. And we had asked for some questions from the viewers. And one at Job Nyakego from Twitter asked, what are the signs of diabetes and how does one cure diabetes? Okay. So we'll start just from there. What are the signs? How does one know that they are diabetic or they're likely to be diabetic?
Okay. So probably I would draw it back a little and say, what is diabetes? And then I will talk about the signs for the sake of the viewer who might not know what diabetes is. So diabetes is a condition where the body is not able to handle sugar properly, if I may just use layman terms. So within our body is an organ called the pancreas that produces a hormone called insulin. Hormones, chemicals within the body like estrogen, testosterone, those that we know. So insulin is one of those. And whenever you take a meal, insulin shoots up because it acts as a key that opens the cell for the sugar to go into the cells, to be metabolized and to produce energy. Our body is wired so that we use glucose for energy. So diabetes is a condition where your pancreas is not able to mount production of insulin commensurate to the sugar that you're taking. So when you have that, your sugar starts going up, and when sugar is up, despite the sugar being up, it's not getting into the cells. So, for example, if you are diabetic and I test your sugar, you'd have a sugar of 20. I have a sugar of 4. Yet I am more strong than you. You would expect you are the one who is stronger. But because you're lacking that small component that is a key that opens the cells for the sugar to go in, then you have diabetes. So when that happens, the sugar goes up, and it begets these symptoms that my friend is asking about. So you have a lot of sugar within the blood. That makes sure that you go to the toilet very frequently. When the sugar gets into the urine, it pulls along the water, so you urinate a lot of times. And with that urination, you are so thirsty. So you'll find somebody who drinks water over and over, and you'll find somebody saying, I never get quenched my thirst, and they will be going to the toilet very frequently. That's one of the key signs. Now, those are the ones that sometimes surprise people and come to us. Now, the others are usually loss of weight or lack of energy or feeling ill, or amongst women, you would find they have infections because as the sugar is going up, for example, candida infections, you'll find women coming with candida. And others now are the longer-term complications of diabetes that would bring people. It's sad that you mentioned there in the figures that about 60% of the patients or the people who are supposed to have diabetes don't even know them because even they are not tested. While I was coming into the studio here, I always make a point of asking the people who are guiding me and everybody I meet whether they have tested themselves. And I can tell you nobody amongst them, I've not asked the two of you, probably in the last 1 year you have not tested yourself. So that 60% is actually very accurate. 60% of us just stay and wait. So most of them come with complications. You'll find somebody come with complications on the brain, maybe have a stroke. People come with wounds that are not healing. People come with kidney issues. People come with sexual dysfunction. And as we're trying to investigate them, we realize, oh, this man, this mother has been living with diabetes for more like 20 years. So these are secondary complications. We wish that we would diagnose them early enough to avoid those complications. So the complications and the signs merge together to cause the hallmark of diabetes.
Okay, then I'll come to you, Dr. Kimbui. How do we manage diabetes from a pharmaceutical point of view? I know we have other forms of management where we get from diet to change of lifestyle, which we shall get to, but how do we manage diabetes from a pharmaceutical point of view?
Diabetes is managed by several drugs. You can manage either by drugs or by insulin. It's based actually on which type of diabetes you have. Type 1 diabetes is what is normally managed almost exclusively with insulin because your pancreas is basically not producing the hormone that Dr. said called insulin. But the other forms of diabetes, type 2 diabetes, which is essentially caused by lifestyle changes, you can manage it with drugs like metformin or pioglitazone, depending on what the doctor sees. There are very many new molecules that are being used. But in the pharmacy now, from a pharmacy point of view, we are supporting also the Ministry of Health now as Good Life, basically in screening. So we offer free professional services for screening for blood glucose and also blood pressure monitoring and BMI. And we also provide pharmaceutical care advice, basically on how to use your insulin, different sites of injections, what sort of side effects you're going to have when you're using your medication. Again, encouraging people also to change lifestyle, because lifestyle also is a key component in the management of diabetes, your diet, your exercise. And we try to give this kind of advice to give a holistic care in the management of the diabetic patient.
You've mentioned something quite important in that depending on the type of diabetes, it could either be insulin or medication. Maybe, Dr. you can just tell us, maybe somebody's wondering, when does one know when to use insulin or when does one know when to use this other medications?
Let's call them oral.
Yes, oral medication, yes.
So maybe picking up from where Dr. Kimbui has explained, and I'm happy that he has brought the issue about the types of diabetes. So broadly, we talk about, for the purpose of this, let's talk about 3 types of diabetes. So you have type 1 that he has talked about. You'll find it mostly in children. These are people who are born maybe normally, but then the beta cells that produce the insulin have been consumed by some mechanism. Also, their pancreas is not able to produce insulin whatsoever. Then we have the type 2s, which you'll find mostly in adults and young adults now. Me and you, probably we are headed there unless we do something, I can see. And then we have the third one, which we'll probably talk about later, which is gestational diabetes that you find during pregnancy. So now, zeroing in on the treatment, take an example of this child who does not have beta cells that produce insulin. The oral drugs, how they work is that they whip the few remaining beta cells to work extra hard to produce insulin. So the type 1, you cannot give them the oral drugs because there are no beta cells to whip anyway. So type 1, you will exclusively find them being replaced insulin. You'll find them being injected with insulin. The type 2s, because they have a beta cell mass that is reduced but is not producing enough, but if it was challenged by some drugs, it can work faster, and if the resistance is reduced, then orals can work. So by and large, for the public, you could say that mostly people with type 1, you'll find them with insulin. People with type 2, you'll find them with orals. But I must hasten and say, occasionally, people with type 2, and many of them now, you'll find them on insulin. It is actually a very good drug because it is resting your pancreas. And so we don't, in the past we would say, oh, the type 2s are insulin non-dependent. We don't use those words anymore. And the type 1s are insulin dependent because they was causing that confusion that, oh, I'm a type 2, I should not be on insulin. But we are saying that exclusively type 1s cannot be in oral, but type 2, you can find some people with orals and with insulin. And then, of course, the third type being the one that happens in pregnancy. What happens in pregnancy when a lady is pregnant, many hormones are produced. A lady has many hormones to begin with. But then when they are pregnant, many more hormones are produced. Now, hormones are antagonistic or are anti-insulin. So they resist the function of insulin. So when a lady is pregnant, they have to be able to produce more insulin to counter the effects of the many hormones that have come. So if a lady is not able to mount that additional insulin, then they get what we call gestational diabetes. And when they give birth, because the hormones again come down, the normalcy comes. So we say it is gestational diabetes when only it happens during the status of pregnancy. But there is also a woman who might be diabetic, and then they become pregnant. So that's not gestational diabetes. It is a lady with diabetes who gets pregnant, and they're a bit different. Maybe we can talk about them later when we are...
Okay. So now talking about gestational diabetes, where 1 in 7 births across the world are likely to have or are likely to be from a mother who has had gestational diabetes. Then as a woman, probably I'm not at risk of diabetes or I've not had any history of diabetes. How then do I know that I'll not be in 1 of the 7?
1 of the 7. And 1 in 7 is a significant number. And the thing is, during ANC, during time when you're going to the ANC clinic, that's why we insist on all women when they are the earliest you know. There is no waiting until, in my village, the women wait until the abdomen is big enough to say, now I qualify for clinic. No. The minute you know that you're pregnant, that would be the time to go to the clinic. And in the clinic, of course, they measure the many other things, the blood level, the many other diseases, HIV, and now we're insisting they must measure a random blood sugar to ensure that they detect those who have gestational diabetes or those who might have diabetes, but they were not detected earlier, and now they are pregnant, and that's an opportunity that has presented for them to be tested. And if it's not detected, gestational diabetes has a lot of complications to both the child and the mother. Because of the lot of sugar that is going on in this pregnancy, the baby tends to be big. And a big baby presents complications during pregnancy and at birth. Delivery. So it's good for us to know earlier. So we are trying to see how do we integrate the screening into the maternal ANC program so that they're able to detect them. The most fundamental thing about knowing the status of a mother during ANC is that if you have suffered GDM or gestational diabetes mellitus, you have a 50% chance of suffering type 2 diabetes later in life. So this lady who, after delivery, things go well, that lady, we should follow them up because they have a chance of either or not. 50% is quite significant. So we as a department are trying to say that just because the diabetes went after delivery, we are not through with you. We want to make sure you change your lifestyle, you eat well, we diagnose you, we screen you every year so that we diagnose you early enough to avoid you having full-blown type 2 diabetes later in life.
Okay, all right. Dr. Kimbui, how affordable is it to live with diabetes? We know diseases like HIV and TB, people get free treatment, but on diabetes, people have to buy this medication. How affordable is it to be on a daily dose of insulin or the oral medications for life, that is?
Well, unfortunately, in Kenya today, management of diabetes is pretty expensive, especially where you have a population where a lot of people are under $10 a day. You'll find in the private sector, your insulin costs anything from 2,000 to 3,000 shillings for proper management. But I do know there are programs available in the Ministry of Health that have subsidized cost of insulin and other diabetic medicines. But overall, it's pretty expensive to manage this condition currently. Again, the non-communicable diseases are not as well funded as the HIV, TBs, and malaria. So these people are actually really suffering on the cost of the drugs.
So, Dr. I come to you as the head of the non-communicable diseases at the Ministry of Health. What are we doing then to help people living with diabetes? Because it's a lifelong illness. There's no point where you'll say, now we have cured it, because it's about managing for life.
Let me start where Dr. Ari stopped to say that over the years, from independence, if I may say, because of competing priorities, you know, the infectious diseases were what we were dealing with mostly. And in fact, at one time in the 80s, in the 90s, when we were in school, you remember people would say NCDs are diseases of lifestyle or for the affluent. Now it has changed. In fact, poverty is a pertinent issue in NCDs. Now, diabetes is expensive to manage, that I must say. But we usually, as government, try to look at the whole picture and say that if you are not controlled, the cost of inaction far outweighs the cost of action. Let's start from there, that you would be saving a lot by acting on it rather than not acting for it. Now, we as government, realizing that the cost is very high, have entered into some partnerships that have tried to bring down the cost of insulin. I'll talk about two, which are flagship projects of the government. The first one is called the base of the pyramid. The base of the pyramid targeted the working poor who are in the base of the pyramid, who have just some little subsistence, some little cash. They can be able to sustain their insulin if you support them. And this was a partnership between the Royal Danish Embassy, the Ministry of Health, Novo Nordisk, a manufacturer of insulin, KDDA, which is a patient support group, CHAC, KCCB, MEDS. Many organizations came together and said, suppose we forego a little of our profit along the procurement chain and make sure that we pass that to the patient, so that the price moves from 2,000, 3,000 to 200 shillings a vial in a district hospital, or 500 shillings if it is within faith-based hospitals or in the primary care. 500 is much more affordable. Now, the biggest challenge that used to happen earlier with insulin was because of the cost and because of the erratic supplies, people would buy in bulk and hoard. And it would expire on them because insulin is a life-saving drug. If you don't have it, you're dying. So patients would hold it. But I can say for the last 5, 6 years, the supply has been stabilized by this to make sure that it's available. These companies have assured that it would be available. The supply chain is now very intact. The cold chain insulin has to be kept cold, and the price has been very stable. We have worked with the patient support group like the KDDA, the Kenya Defeat Diabetes Association, to call out and say, oh, there's a pharmacy here that is exceedingly putting the price of insulin so high. They say, okay, that's a business. Why don't you go to the district hospital? Why don't you go to a pharmacy that is bringing down? So ultimately, the price of insulin has come down to a manageable level, but still, it can still come down because it's a lifelong treatment. The second one would be what we are calling the Changing Diabetes in Children project. We have close to 1,000 type 1 diabetes children who are, I don't like calling it free, it's insulin at no cost, because somebody pays for it somewhere. But to the patient, it's at no cost. And every child who is diagnosed of type 1, wherever they are from this Kenya, whether they are from very rich families or poor families, they can be enrolled in this project, and they can get insulin at no cost, they get a glucose meter, they get strips, and they get education, and their parents also get educated, because these type 1 children must be on insulin. So you can imagine children who, if she doesn't get insulin for 2-3 days, the next day, she's in the hospital. So we are trying to work with the private sector, because hitherto we have really probably not taken advantage of the private sector and the inputs that they can work with the public sector. And I'm happy that Dr. Ari here is already, if you look at the World Diabetes Day, they're already screening the members of the public, and they're partnering with us. So I think those are two of the main that I could mention. But maybe I just hasten to say that the government is trying to see how NHIF can also pay for outpatient medicine for NCDs. In the past, of course, NHIF has paid for inpatient. My mother, if I use her example, she pays for NHIF, and sometimes she asks me, these guys are waiting until the day I will be admitted for this thing to help me. So it does not incentivize her, because NCD or probably diabetes is an outpatient medicine, is an outpatient disease. So if you're not paying for my monthly insulin vials, this insurance is not helping me. So we're trying to see how do we rebate for it as an outpatient to keep the patient as outpatient as possible, and also to incentivize them to pay.
Okay, all right.
Also, Dr. Masia might add, at least in our pharmacies, what we're trying to do is essentially offer our patients also more affordable solutions. So what we're doing, we're also giving them awareness about generic medications. And we're also doing planned procurements where we're looking at the numbers, and we work with pharmaceutical farms, because the bigger you buy, the more discounts you get. And we try to reflect this to the patients that come to us. So we tend to try and have a cheaper solution. So when you come into our pharmacies, you can always walk out with a solution, regardless of your affordability.
Okay. And one of the other questions we received is asking whether diet alone can manage diabetes. So I'll start with you, Dr. Kimboi, for this viewer. Can diet alone manage diabetes without the need for insulin or the oral medications, as you have explained?
I honestly don't believe diet alone can, but diet is a very big contributing factor in diabetes management. I know eventually if you manage your diet and exercise and all that with type 2 diabetes, which is essentially lifestyle choices, diet will really affect your outcome. But for type 1 diabetes, I don't think diet will have any effect. Yeah, on it.
While we are training the patients living with diabetes, and we do a lot of training for patients living with diabetes and community health workers, we usually equate management of diabetes to the African stool, you know, the four-legged stool. And we say there are 5 issues that are critical, or let's put them as 4. So you have education. Awareness is very critical for a patient who is enlightened and knows about their diabetes is far better than a guy who is quite ignorant. Then there is physical activity. Mazoezi is a must, and it's not about running into the field. It's about doing your usual job, walking instead of using the motorbike, putting exercise within your lifestyle. 3 is diet. And diet is lishe bora. We say eat a lot of vegetables and fruits and less of carbs and a less meal. We eat a lot, I think, as Kenyans. So, for example, we tell people, kula mboga na ugali, not ugali na mboga. It's supposed to be the bigger portion would be the mboga and the smaller one, ugali. So 3 is diet. And of course 4, which we do not demean in terms of meaning, is drugs. You know, people usually run to the drug first and forget all these other 4. And we say, if you look at this African stool, it cannot stand on one leg, or like what he's asking. Can diet alone, if you sat on one of those legs alone, it will actually hurt you. So you need all the 4 together. Most importantly, education and diet, and drugs come in to just wrap everything together. And also physical activity should not be left behind. I must say here, that because of the chronic nature of diabetes, and it being a long-term thing, most of the patients are very gullible. They're very easy to lie. You will see all sorts of products in the market. Food for diabetes, I don't know, there's even sabuni, even toothpaste for diabetes. I mean, our patients are very gullible. And since they're looking for a healing solution, you sometimes get tired with this disease that is not going. So they are cheated a lot. And I would know that probably that is somebody who has been told that with diet you can manage your disease. It's okay, it's important, but you also need education, you also need physical activity, and more importantly, you also need drugs.
So for type 2 diabetes, is there a point where if it's well controlled, well managed, a patient can be put off medication?
Well, we usually say this. Take an example of, let's just look at what is happening to the body. So your beta cells are like, take an example, a lady when they are born, they have mayai uzazi. And those eggs reduce every month. Until one point, we say you are in menopause. Zimekwisha.
Yes.
So that's the same thing that happens with the pancreas. So the pancreas is just an organ like any other. The beta cells that produce the insulin go reducing about 7% every year. Until at one time, they're no longer there because we are degenerating. So some people, it happens very fast. Some people, it's slowly. So now you have type 2 when the threshold of those cells are so fewer than the amount of insulin that you require. So then we start you on insulin and you are controlled well. So now the question comes, how then would we say you've reached a point where you can be put off drugs because the beta cells are still low? And sometimes people feel well, drugs now, they have made me feel well, and they are tempted to withdraw. And when they withdraw, that up and down destroys some of the organs. It can destroy the blood vessels, can destroy the nerves, and those are the things that bring the complications. So we say, once you are living with diabetes, this is a lifelong thing. You need to embrace it and becomes part of your life. And we are trying to deal with the psychosocial issue with diabetes because a lot of patients have depression, anxiety, wondering, how will I take this for the rest of my life? How will I afford? Can I be withdrawn from this thing? So we first of all give guys education to understand what is happening to your body. Once you have understood, then it's easier for the patient to go this journey together. And it's not a journey you take alone. That's why we tell people, join support groups. For example, within a support group, you get people who have been in this disease for 40 years. You've just done 2 years. So you get encouraged. So you can't deal the journey alone. Okay. You need others along the way.
Okay. And I know we had covered this, but a question just coming in. Can it be cured, Dr. Kimbui?
Well, as Dr. has said, using the African stool, yeah, you need all the 5 pillars. And yeah, as in, I guess there are cases that they have been cured, but I think you just have to accept you have the diabetic condition and continue the management.
Okay.
Yeah.
Then the other one coming in is that How does one avoid the complications of diabetes? I can start with you, Dr. Kibasho.
Okay. And probably just to throw in my words about the curing is diabetes can be controlled, can be managed. That is the word we use. Curing means that I no longer have diabetes. It's usually a dicey thing to use. It's usually a dicey word to use. Some people, as I said, maybe were in what we call pre-diabetes. Their beta cells were not so many anyway. Then they engaged in a lot of physical activity. They ate well. And so the body, they were obese, so it came down to a lean, so the insulin they produced became enough. And they say they are healed. It is true, they have, but it's just a regression of the conditions that was causing the diabetes. So I am usually not very keen on using the word cure. I say diabetes for sure can be managed and can be controlled. If you have diabetes and I don't have diabetes, our risk of having these complications that we usually talk, the stroke, the eyes, the blood vessels, the heart, is the same if your sugar is controlled. But when your sugar is not controlled, your risk of having a stroke is 2-3 times my risk. So we usually say, yes, you can prevent these complications by controlling your sugar, by making sure that you test your HbA1c. We have a test called the HbA1c.
Yes.
The HbA1c looks at how much sugar you have over an extended period that is affecting your blood, if I may use layman terms. And we usually say, if you're managing your diabetes and you're not doing the HbA1c, it's like driving a car in the night without the lights. Fine, it's moving, but where is it going? So we usually tell patients, make sure that every 3-4 months you do a HbA1c, and you can find it in many hospitals. And I would actually urge clinicians from this platform. A lot of clinicians don't prescribe this to the patients. Patients don't know that they need this test. You know, we went to school on behalf of these guys. So we need to prescribe. Sometimes we keep it away from them, not because we want to, but because we think he can't afford it. But if it is the best thing to know where they're headed, then we should do it. So sometimes I don't even blame the patient. But even if you're a patient, you don't need permission to do a HbA1c. Just walk into a lab and say, I'm here, I want to do my HbA1c to know where my status is. It should be around 7%, 7.5. If it is below 7.5, that means you're headed in the right direction. Your treatment is okay. If it is above 7.5, 10, 14, then you need to go back to your doctor and say, something is wrong. We need to talk.
Okay. So now, as we wrap up, the World Diabetes Day is coming up on Tuesday, the 14th of November. And you had mentioned that you're helping the Ministry of Health screen. And you know, finding out whether one is pre-diabetic, meaning not diabetic, but they're at risk of getting diabetes, or knowing whether they are diabetic so that they can start on treatment is quite important. So just your final comment on the screening that is ongoing in preparation for World Diabetes Day. And secondly, when it reaches that day, do we stop or do we continue?
Okay. Good Life is supporting the Ministry of Health in actually screening, as you've said. But this is what we're calling random blood sugar testing. So if we notice, obviously, if the results are very skewed, we have a referral system that they've actually provided to us. And these are services that we've actually been offering before and will continue offering even after the World Diabetes Day.
So how much do I need to pay to come and do the screening at Good Life?
Currently, it's free.
Okay.
Yes.
All right. Dr. World Diabetes Day is coming up on 14th, and I know you have something lined up.
Yeah.
Just tell us as we wrap up this discussion.
I must thank Dr. here for partnering with the ministry. I can tell you public-private partnerships yield a lot, and there can be a win-win in these partnerships, and I'm glad that they are giving it free. It's not very cheap. Every strip costs money, close to 50 shillings. So when these, and I'm sure you'll have a lot of guys at your doors from this show, do what you can. But as a ministry, we have partnerships across. We have some guys called Baba Absako who have helped us with a lot of strips. We have KDDA, we have the DMI Center in Hurlingham that we work with very closely with the National Diabetes Control Program. And so we will be screening people, as many as 10,000 people within that day. Our campaign is usually the whole year, but there has to be a highlight. So the highlight is on 14th. But we usually say we don't stop on that day. We usually want it to be the whole year. So this year we'll be screening across several counties, like 6 counties. They'll be screening in Nakuru, they'll be screening in Nyandarua, they'll be screening in Kisumu, in Kisii, sorry, they'll be in Kericho, Nyeri, they'll be screening in Mombasa, they'll be screening in Embu. But the Embu one is the highlight where the national event will be. So within this Embu screening, we'll do community health workers will be screening across the homes. But on that day, we will also be working with children with type 1 diabetes, call their parents, so that we talk about lishe bora, how to cook, making the the healthy choice, the easier choice. There is no diabetic diet, as we would say. Chakula ile ya nyumbani is this very same, very healthy. It's just about portions. Because zamani, when somebody was having diabetes, they're told, oh, you must eat this. It becomes another bother. So we are trying to engage these parents to tell them, how do you cook for these children? How do you integrate this cooking into the home so that it is wholesome? So for World Diabetes Day this year, we are saying, it only takes 5 seconds to know your status. And even if you're being charged, I have not seen any hospital charging more than 100 shillings to know your status. Just 5 seconds. So you go on out of your way, walk into any district hospital, any health facility, any Good Life pharmacy, any of those facilities, please get to know your sugar status. Because if you don't know now, the next time you're coming 10 years from now, you'll be having a complication. And it's so difficult to roll it back when the complications have set in.
Okay. Thank you very much, gentlemen. Thank you for your time this evening. I'm sure we have shed a lot of light on diabetes and management. So that is all we have for you tonight. We're discussing diabetes, living with diabetes and managing diabetes. And with me was Dr. Kibasho Mwangi, who is the head of the Non-Communicable Disease Unit at the Ministry of Health, and Dr. Robert Kimbui, who is the chief pharmacist at Good Life Pharmacy. Until next week, where we'll have another discussion, another topic on matters that affect your health on Health Digest. I'll wish you a very good night and a very blessed rest of the weekend until we meet again next weekend. I'm Dr. Masi Korir. Enjoy the rest of your viewing.